ഇതെല്ലാം പഴയതാണ്. ഇതെല്ലാം
പ്രിസൈസിന് അഡിനോയിഡിന് വേണ്ടി.
The idea is to pass in an end to the posterior end, hold it straight. Just don't move your hand beyond this point. You have to keep the endoscope, don't pull it out also. Check it out. Always check the scope. What you do is generally keep the saline out, make sure you check it and see if there is enough blow over there. Once it's ready, you pass in the endoscope. See, I have not bent the coblition guard at all. Idea is to reach up to the one. The bond is right up to it. And I use it right over here, primarily bond the one area over here. That's the area first I would want to do. And then all the bonds are like a millimeter away. If I stay a millimeter away and take it as very slowly as possible just to take out the mucosa. Okay? If you have any clouding or anything of the field, you basically ask your scrub to irrigate. You stay a millimeter away, you can see there's a lot of energy which is getting delivered over there. You can see a lot of ventilation which is happening at this level also. You primarily are going at that pace. You don't need to hurry it up either. You're just going at a very slow pace. Making sure you just go all the way deeper. If you see this black charring, that's because you are too close to the tissue. Stay a millimeter away, there's not too much of a charring. That is how it should be. Right? This is 9 dot of that. Ideally, your operative thing will be on the 7 alone, but 7 is a little. I am used to doing it a little higher pace. You can do it at 7 itself. I go as close to the incision tube opening as possible, but leave the superior part always. You can actually burrow this part over here. You can just go around, burrow as much as possible. There is invariably one bleeding vessel from here. That's the only bleeding vessel which can cause you little trouble. Some branch, the ascending pharyngeal, is really not described much in textbooks, but it's always there, invariably. If you don't do too much of coagulating around this area, that's something which you see most of the time, invariably. So, and see how the wand is held. The wand is held like a small, like how you do a pencil, like how you use a Sinclair thumbs. See, one thumb is over here, the others are over here. That's and then you can roll it around. And I'm not holding it tight. If you hold it tight, by this time your hands hurt. The other method I do is something called a curating. A curating actually helps to debulk these tissues really fast. You can actually debulk it really well, and this whole procedure finishes off faster. So you can actually take out a larger chunk of tissue. You're bleeding at the then you don't need to actually coagulate it. And the moment you start seeing a little more bleeder, you know that you're close to the perimycin. Okay? So I will just show the level at which you want to go. When you coagulate, it's very important to take. To take out this coagulate correctly, you won't have much recurrences issue. But the recurrences are tissue. And what I do is I generally take out some amount of tissue from this nostril itself. I don't really go to the other nostril unless really required. Only for the finishing job, I'm going to chair on it. Do like that, in your centers slightly different. And the inputs, do like that. And what you can see, you can go in tissue depth by depth, overnight and everything. Tissue matter side of home eppozhum kai vedanayilla invariably. So better to take out as much tissue as possible from the other side.
How do you know what that is called?
I will show you. This is just still at the level of the perimycin epithelium. The perimycin will come up in a moment. So now you have almost uniformly reduced it to whatever visual angle you are seeing. See this level over here, okay? And even when you are looking at it, you start seeing the slow graying of tissue on the wall. You can see that. That's all you really require to go. Anything beyond that muscle, ഞാൻ ഇവിടെ ഒരു സ്റ്റെപ്പ് ടിപ്പ് പോയ മസിലാണ്. ഇത് ശരിക്കും പറഞ്ഞാൽ ഇത്രയും വരെ പോയാൽ മതി. Anything beyond this grey tissue, you end up with a ചെറിയൊരു white plane കണ്ടുവരണം. In this case, a white plane കണ്ടുവരുന്നത് തൊട്ട് പെരിവേഷൻ കഴിയുന്ന സ്റ്റേജാണ്. That's all you require to do. Anything beyond this is actually an overkill.
That's like the septum. That pass goes to the septum. Then you bone, right?
Here is bone, yeah. ഇവിടെയെല്ലാം ബോൺ പോലെയാണ്. ഇവിടെയെല്ലാം ബോണി ഫീൽ തന്നെയാണ് കിട്ടുന്നത്. ഇവിടുത്തെ ടിഷ്യൂ നല്ല ഫ്ലഷ് ചെയ്ത് തന്നെ എടുക്കുന്നത്. അപ്പോൾ കുറച്ചുകൂടെ നീറ്റായിട്ട് കിട്ടും.
You never expose that.
You never expose the bone. ഇവിടുത്തെ ബ്ലീഡിങ് വരും. ഇവിടെ അടിക്കൽ ഒരിക്കലും. The posterior and the septum. Generally ഇങ്ങനെ അടിച്ചു വന്നിട്ട് generally do this once bite and that's where it can bleed.
പെരിമേഷൻ ട്രേസ് ചെയ്യേണ്ടത്.
Perimation just about tracing out.
നേസിൽ എന്താണ് മറ്റേ എന്താണ് ഈസി?
ഇത് ഇവിടുന്ന് easier. എപ്പോഴും easier from the funnel end. ഇവിടെ എപ്പോഴും easier to trace out. And if you don't go beyond this depth, it's really not required. നമ്മൾ പ്രോപ്പറായിട്ട് ചെയ്ത് കഴിഞ്ഞാൽ ഈ ഡെപ്ത് is great to finish off the case. ഡെമോൺസ്ട്രേഷൻ എടുത്ത് മാത്രമേ അത് കൂടുതൽ ചെയ്യാവുള്ളൂ, അല്ലെങ്കിൽ വെറുതെ ഇവിടെയൊക്കെ actually you can slowly, and I'll show you why. Because what we end up doing is finally, see, this is at the level of the uvula, E level. നമ്മൾ wide angle slope ആകുമ്പോഴത്തേക്ക്, so when you do this, you can see the uvula is coming up. ഇത് ചെയ്യുമ്പോൾ എപ്പോഴും remember that it doesn't hit the uvula. Generally, vein വരുമ്പോൾ കൂടുതലും uvula burns വരണം. If you feel that it's coming very often in your field, put in like an infant feeding tube and hold the uvula on the other nostril. Okay?
The inferior limit is.
Inferior limit just up to over here. I would say a couple of centimeters below the level of the gestation opening, right up over here. ഇത്രേ മാത്രമേ.
താഴത്തേക്കുള്ള വേണ്ടല്ലോ.
Really not required because ഈ ഇരിക്കുന്ന level is at the posterior pharyngeal wall. നമ്മൾ ഇവിടെ വരെ അടിക്കുകയാണെങ്കിൽ പോസ്റ്റ് ഓപ്പ് നോക്കുകയാണെങ്കിൽ ഇവിടെ ആക്ച്വലി posterior pharyngeal wall ആണ്. യുവിലേക്ക് താഴെയാണ്.
അവിടെ വെസലും ഉണ്ട് തോന്നുന്നു സാർ. ആ താഴത്തെ ബ്ലീഡിംഗ് വെസൽ ഉണ്ട്. അല്ലല്ല യുവിളുടെ ആ സൈഡ് സാർ പറഞ്ഞ ലെവലിൽ ഇത്തിരി താഴെ. ഇവിടെ
ആക്ച്വലി വെസൽ യു കൻ സീ പൾസേഷൻ കണ്ടോ? ഈ കാണുന്നുണ്ടോ? ആ പൾസേഷൻ ജനറലി സം ബ്രാഞ്ച് അസെൻഡിംഗ് pharyngeal. അത് I ran extensively, not many have actually described. ഇത് തൊട്ട ബ്ലീഡിംഗ് നന്നായിട്ട് ബ്ലീഡിംഗ്. You can see the pulsations around it. ഇത് കരോട്ടിഡിൽ വരുന്ന ഇവിടെ ഒരു ബ്ലീഡ് ജനറലി ഉണ്ട്. ആ ബ്ലീഡിംഗ് ഏരിയ കാര്യമായിട്ട് പോയി തടാതിരിക്കുന്നതാണ്. അതുകൊണ്ട് പ്രത്യേകിച്ച് ഗെയിനൊന്നും ഇല്ല. ഇതൊന്നും എയർവേ സ്പേസിനെ എഫക്ട് ചെയ്യുന്നതല്ല. When you are doing it from the transnasal part, you don't even see this. You will be only doing it this area. This is the only area you need to address. It is not posterior pharyngeal wall outcome. There is no need to actually take out everything of the passerine ridge. More or less, you see that I am saying a millimeter away. You can see this round glow over here.
You are not touching actually.
I am not touching. I am only hovering. If you touch, you won't get coblition.
Okay.
Now, what I do invariably for all the cases is, even if there is no bleeding, if there is even if there is no bleeding per se over here, I could do a coagulation with multiple areas over here. പല areas, ചെറിയ coagulation spots. ഇപ്പോൾ coagulation ആണ്. How do you make out the coagulations? One is the sound difference. Okay. So why I want to do that is, ഇതൊക്കെ ഈ coagulation നിൽക്കും. അതൊരു press ചെയ്തിട്ടാണ് ചെയ്യുന്നത്. Now, what I do at these levels is to primarily make sure that gestation to open eye and the factor over here. What we do at this junction is primarily to make sure the slough doesn't fall off continuously. This is not a problem when you want a slough part, as of now. So you don't want the slough to fall off at one go. That is why I am doing this coagulation bouts. Multiple coagulation regarding this slough to bleed over palavala angle and bleed. When it falls off, it can have bleeding.
So does that cause pain?
No, it doesn't.
Random spots, sir.
Random spots. There is no bleeding in any of these places. But I am doing it because of this reason, that when the slough falls off, it has to fall off as one go. Okay. But the key part you look at it in this case is I haven't taken out the endoscope at all. If I take the endoscope multiple times, it's going to bleed from the nasal septal area or from the turbinate, and then the field becomes messier. Now, if it starts bleeding from the washer, I would ask my assistant to wash it along the scope. I would do in the first case about it. Here, washer. Don't put out the scope. This washer is more than enough for you to actually get the area completely clear. There only change the outside. Defogging wash. Always wash. Don't pull out the scope. You pull out the scope, invariably you traumatize. You do only one time. Right? And once you take it out, you ask the scrub to actually do the cleaning if required. Block ആയിട്ടില്ല pack removal. ഈ pack removal വെക്കുന്നതിൽ കാര്യമില്ല. Pack വെക്കുന്നതിൽ കാര്യമുണ്ട് because that itself decongests your nose. And go on the floor. Invariably there will be one area which is left here. You saw that. അപ്പോൾ ആ ഏരിയ കൂടെ അഡ്രസ് ചെയ്യണം. എത്ര എൻഡോസ്കോപ്പി ചെയ്താലും ഈ ഏരിയയിൽ എത്തും. ഈ ഏരിയ എന്തായാലും കോംപ്ലീറ്റ് ചെയ്തില്ലെങ്കിൽ എൻ്റെ ഫാമിലി. പക്ഷേ ഇത്രയും നല്ലതായിട്ട് ക്ലിയറൻസ് യു നോട്ട് ഗെറ്റ് ഇറ്റ് ഔട്ട് ഓഫ് എ ഡിവൈഡർ ഓർ എനി അതർ മെത്തേഡ്. Would you guys agree? Any disagreements on that? That is what I was saying. But there is always the possibility of leaving everything around in case of doing any other method. For me, this has been useful because of this reason that you are actually you can visualize and take out how much you want to. Just medial length full. But adiosha illa because it will basically fibrose and it will revert back. But don't take the lateral. You take lateral and fibrosis one institution dysfunction. ഇവിടെയാണ് ഞാൻ പറയുന്നത് don't go deep inside. Surface കുഴപ്പമില്ല. Deep പോയാൽ bleed വരാം. എന്നാലും കുഴപ്പമൊന്നുമില്ല. കൺട്രോൾ പക്ഷേ that's something which can always happen. Actually, adenoids take more time than the tonsils. Adenoids are just 15 minutes side. But tonsils are shaking for some time. If it was some other fraction, tonsil is not allowed. But over a period of time, you will realize that the time taken is more or less same, unless it's like really bad tonsils or adenoids. Whoever prepared are you know it. See the shaking very nice. That white. That's where your limit is. Now, like the surface of the layer, if I remove off the whole thing, you can see the very nice stripping off the job. That's very nice. A lot of surgeons, what I've seen is they take off this whole thing up to the very nice. You can leave some bits here and there around the very nice.
Sometimes you see the muscle twitch when you work.
Yeah, you can work. Is it a muscle?
But actually, it should not twitch.
You should not. If you just stay above it, then you won't have a problem. And I am just randomly again doing this coagulated things because from slough falling out somewhere, you don't have to panic. And if you say, oh, the trauma or the child will actually split out the whole slough and it will bleed. And that's not very pleasant for the parents.
After you started cauterizing, it's reduced.
After I started doing this, it stopped. I started doing this over a period of time to realize that the slough falling off stuff of falling is the institutions are functional, bubbles are coming up. This sounds good, anything more you guys want to do, here also concessions are around. But I would really leave it at this stage. After exposing the vitamin, you know that this is the same level. There are some tissues around over here. If you have level really not required. And the pain will be adequate. The work is almost done. You don't really require to do anything further also.
So those contributions in the inferior end
actually. But that's the airway affecting
but that's also adenoid tissue, isn't it?
Adenoid it's a part of the body as well. It can be anything. But really, addressing out it's not going to give any airway difference. Airway is not going to change the thing. And why you are researching?
Will you for post-nasal treatment later on, sir?
Post-nasal?
Adenoid tissue. ഇരുന്നിട്ട്.
Pretty unlikely. Okay? That's probably a link to pack it around.